with most of everyone joining us. So Steve, I'll just hand over to you.
Thanks, Danny. Thank you very much. And welcome, everybody. I hope you enjoy the webinar tonight. I'd like to start on a somber note. Sadly, I found of the very recent passing of one of the great sonographers in Australasia, that of Sue Caitchen from Canberra. I did regular work in Canberra for for about 4 years actually, and found Sue to be inspirational and dedicated, passionate, everything I love about a sonographer. She was the embodiment of all of these qualities, and to the point where the local sonographers would refer to her lovingly as Mother Hen, because she would dote about after them and look after them. So Sue sadly has passed now, and died of a rare cancer which has taken her life far too soon. And she was fit and active and bushwalking and everything you would want to be. So I just I'm very saddened by that news, and no doubt many of you will have met Sue and know her well, and I feel for her family and all those that are left behind by her. Now let's move on to ankle inversion injuries. And ankle inversion injuries are very common. It's about the easiest thing you can imagine doing in the musculoskeletal system. If you're trying to hurt yourself, this is a very simple way of doing it. It is done very easily, usually by a combination of these, which look sexy but are not really that functional, and then a bit of this. And if you combine those two things, you're quite likely to get an inversion injury. If you then add a bit of this, you're almost certainly going to get an inversion injury, and that's what will happen to you. And you look sexy wearing them, but you don't look so sexy in a moon boot. And it takes a special sort of girl to look sexy in a moon boot, and some may be able to do that, but not many. So inversion injuries are common. If you grew up in the country and you played footy or you played netball, you're likely to have an inversion injury at some point. So we get asked to examine them very commonly, and our patients will likely look like this, where they have some bruising around the lateral malleolus of the ankle, and then some edema and some further bruising extending over the lateral side and over the dorsum of the foot, and they'll be very tender. And if you look at the other side of the foot on the medial aspect, you'll see in the posteromedial corner here, there's usually a little bit of bruising as well, and that will track down the foot as gravity pushes the blood around. So these injuries will have explanations tonight as to why this bruise pattern occurs. When you do an inversion injury, it's this lateral side of the ankle that bears the weight and the brunt of the force, and it will disrupt and destroy a variety of these structures during that incident, and we'll go through the pattern of what you can expect to see. The reason I wanted to do this webinar tonight is because we're all very good at looking at ATFL and calcaneofibular and perhaps the anterior inferior tibiofibular syndesmosis, but as I've looked at many inversion injuries, there's some other structures that are quite commonly damaged, and some that you may not be looking at routinely, where I think you can value add a little bit to explain the extent of the injury and make our findings much more akin to what an MRI can find. In fact, in many respects, we are well ahead of the MRI because of our dynamic ability and our ability to scan in many different planes along the angles of these little collagen bands. So this is your checklist, and you're going to hate me for this, but it looks like a long checklist. If you've got your iPhone with you, just aim it at the screen and photograph that, because we're going to go through these things one at a time. And most of those things, you look at them and you think, oh yeah, look at those things, that doesn't sound too bad. And then there'll be a few things there that you may not be looking at, which we'll explore tonight as well. So the first thing, whenever I walk up to any joint and examine it, it doesn't matter if it's a shoulder, ankle, elbow, whatever joint it is, knee, the first thing I ask of that joint is, do you have an effusion? And this is a normal anterior ankle joint, and you can see there's just fat laying in here, sitting on top of the talus, the tibia here. This is all talus, and there's no fluid here. Whereas if you look at this one, this is a joint effusion. So we have fluid inside the joint, and this tells us that there is an intra-articular problem. So I think differently immediately about this ankle compared to this one. If you look at this ankle over here on this 50-year-old female, you notice that there's a joint effusion, but you notice that the joint effusion has this very fine-grained, particulate, low-level echo, homogeneous pattern to it. And this is the classic pattern of red blood cells. So red blood cells are superb scatterers of high-frequency ultrasound, and they will produce this type of pattern. And so this is a hemarthrosis. So no matter what I find on this scan, if I find no ligament damage or ligament damage, it doesn't matter to me a great deal, because this person will have an orthopedic injury and they will have fractured their talus or their tibia. There'll be a significant orthopedic injury that needs to be uncovered, and that will often be the domain of a CT or an MRI rather than the ultrasound. When we get to start the ligamentous anatomy, I like to start with the ATFL. It's what I refer to as my canary in the coal mine. If the ATFL is intact, then things are pretty healthy. The moment the ATFL is broken, then it's usually the first thing to break, and then a search is on to see how much other damage has been done. This rule is not absolute. You can have an ATFL that is normal and still have significant injuries to other ligaments depending on the vector of force that's applied to the ankle. But in general terms, an inversion injury will manage to damage the anterior talofibular ligament. This is how I find the ATFL. I put my thumb on just on the lateral malleolus, slide it up to it, and then I put the transducer on top of my thumb. And what this enables you to do is to be scanning on exactly the right spot of the lateral malleolus with the probe parallel to the sole of the foot, and the foot, as you can see there, in a bit of passive inversion, that you'll put the probe exactly on the ATFL every time. You really can't go wrong. If you're not looking at the ATFL, it's not there. It's a very, very simple clinical surface anatomy trick to be able to find the ATFL. When it ruptures, it's important to remember that the ATFL is a capsular ligament for the ankle. In other words, it forms part of the joint capsule. So the ATFL and the joint capsule are one in the same. So when you tear your ATFL, the synovial fluid contained within the ankle joint will spew out into the subcutaneous tissues and intermingle in amongst the subcutaneous fat and underneath the skin. And this is part of the reason why we get such rapid edema when we have an ATFL tear. The other reason, of course, is that the parting of any ligament, particularly if there's a bony avulsion, will cause bleeding, and so you get blood product also being put into the subcutaneous space. That's why you get the clinical bruising. One of the key things to look for with an ATFL injury is these avulsions. So these are little fragments of the talus and fragments of the fibula which have become avulsed during the inversion traction of this anterior talofibular ligament. When you see these bony fragments that have been pulled away from the bone, you know that the ATFL has been significantly disrupted. In fact, the very first journal articles that spoke of looking at the anterior talofibular ligament, published many, many years ago, the ultrasound machines weren't good enough to look at the ligament. They just told us where to put the probe and to look for these little bony fragments. They show up beautifully on CT as well. And of course, this is the correlating patient with ultrasound, and you can see that this is a piece of talus that's been pulled from the bone. The anterior talofibular ligament has been pulled from the bone. The enthesis is very strong. As the enthesis gives way, it pulls at least the calcified part of the fibrocartilage with it, if not a little bit of cortical bone, as it has in this case. This is a very common pattern. Stress test. It's important to stress the anterior talofibular ligament, as it is important to stress all of the ligaments that I'm going to talk about tonight. And you can see as I apply the stress to this looks like an abnormal ligament, looks a little heterogeneous, but then as we apply the inversion stress, you can see the Suez Canal of synovial fluid creeping up through the tear through the middle of this ligament. This is uncomfortable for the patient. In fact, it might be downright painful, so you do it with empathy, you do it slowly, you grade the compression, you do it very gently, and you coax the patient along with the journey. So you should be able to get good inversion stress without too much trouble. Your patient will be compliant as long as they understand what you're trying to achieve and that you've got their best interest in mind. The next bit to have a look at is the calcaneofibular ligament, and the calcaneofibular ligament is notoriously difficult. It sits deep underneath the peroneal tendons, just inferior to the superior peroneal retinaculum, and just proximal to the inferior peroneal retinaculum, which is the level of the peroneal tubercle. So here it is draped underneath the two peroneal tendons, peroneus brevis and peroneus longus. And the way to get such elegant pictures is to put the foot in inversion and dorsiflexion, so inwards and upwards. And as you stress the foot into that, the ankle into that position, you'll stretch out the calcaneal fibular ligament and see this proximal end, the fibular attachment end, a little better. In a normal calcaneofibular ligament, when you stress it and then relax it, it should trampoline the peroneal tendons. You can see the way they are lifted up and then they fall back down. And this really proves that it's attached to the fibula and it's attached to the calcaneum. The joint fluid that you see underneath it is entirely normal. Most people have this. This is a small amount of subtalar joint fluid. It's not the ankle joint, it's in the subtalar joint, really between the talus and the calcaneum here. And that's what you expect to see. When it's torn, the calcaneofibular ligament will look retracted, so it has a sort of humped up, hypoechoic, swollen appearance at the calcaneal end, and then the fibular end will be very, very difficult to discern. And as you follow the fibular end up, you'll see that there is some bony avulsion here. There is a few little loose fragments of bone, and this is where the calcaneofibula has been pulled from the fibula. So these are the features of a torn calcaneofibular ligament. And it's nice that the one feature that's very nice is the fact that it looks abnormal back here where it's very easy to see, and that puts you onto the fact that the fibular end has been damaged. More examples, you can see how swollen and how fat the calcaneal end is here. This is a real sign of trouble that the other end is pulled away, and you can see the hematoma, the small avulsion, and same as this patient on this side as well, two separate patients. When the fibular end of the calcaneofibular ligament is detached from the bone, when you try and do the trampoline test with some inversion and dorsiflexion, you'll notice that the peroneal tendons really remain stationary because there is no tension. While you can see the subtalar joint being stressed here, there's no tension being applied through the calcaneofibular ligament and no elevation of the peroneal tendons. And this gives you some more confidence that the calcaneofibular ligament is torn. This is just a point of interest. I've asked this of a few people, and I'm uncertain as to really the anatomical reality here, but in some patients where they tear their calcaneofibular ligament, I seem to see a communication between the subtalar joint and the sheath of the peroneal tendons. And anyone who can shed light on this for me, I would be delighted to have a discussion with them, because I feel like when you tear the calcaneofibular ligament, then you create this communication between the subtalar joint and the peroneal tendon sheath. I'm not sure that this is well described. The next thing to look at is the anterior inferior tibiofibular syndesmosis. There is also a posterior one, and the posterior one ultrasound shows very poorly, and we really rely on our cousins in MRI to show this component of it, but the anterior one we see beautifully. One of the key features of the anterior inferior tibiofibular syndesmosis is that it lies at a very steep angle, so you're not scanning axial, you're scanning really in the same scan plane as the calcaneofibular ligament, with the tibial end of the transducer in a much more proximal location than the fibular end. So not axial, where you'll be seeing the fibula and the talus, which will have hyaline cartilage like a black line on the top, but steeply angled up so you're putting the tibia and the fibula in the image together. We can stress test this by scanning it with your right hand and having the patient bend their knee and then putting your hand underneath the foot that you're scanning, in fact around the heel, and then internally and externally rotating the heel. So really feel like you're grabbing hold of the talus and then turn the talus internal and external while you scan with the other hand. And what this does by rotating the talus is it stresses the tibiofibular joint and it stresses the ankle mortise. The job of the anterior and posterior tibiofibular syndesmosis is to hold the tibia and fibula together while the talus goes through its rotation and to stop the two bones from spreading apart. If it's disrupted, as this one is, the bone will spread apart, as you can see, and then come back together, and this is an abnormal finding. The other finding here is this little avulsion, and it's quite typical when you tear the AITFS that you'll take an avulsion fracture with it. This one is a little odd in that there's no avulsion, but you can see fat going through the defect in the ligament here. Whereas this one is more typical, where we have an avulsion coming from the tibial end. So this is what we look for. If you have an anterior inferior tibiofibular syndesmosis tear, the patient needs to be worked up more thoroughly because they may have an accompanying posterior tear, and they may have actually split their interosseous membrane open. And this is really a diagnosis. All this is in the spectrum of MRI diagnosis rather than ultrasound. So what we're saying is the patient has a severe inversion ankle injury with multiple abnormalities. We describe them, and then they need to go on for subsequent imaging for orthopedic management. The next structure is the superior perineal retinaculum, and when you invert the ankle, this structure here, which ties the peroneus brevis and longus to the calcaneum just behind the lateral malleolus, will be torn usually from its fibular attachment. This is a normal one, and this is a patient with an inversion injury. You can see edema around the retinaculum, and you can see the bit of bony sclerosis at the enthesis, and the retinaculum is a little unusual looking. In this case, the retinaculum has been stretched and has not ruptured, but it is now a sort of spinnakering, sort of lax, capacious retinaculum that allows peroneus longus and brevis to transpose on each other, causing a click in the lateral ankle. The next structure we look at is the peroneus brevis insertion. And I actually think peroneus brevis inserting onto the base of the fifth metatarsal is a very benign piece of anatomy to look at. I don't see peroneus brevis tendinopathies or tears. It's just not something I see in my clinical practice. What I do see is this other structure that goes onto the base of the fifth metatarsal, which is the lateral band of the plantar fascia, and I see plantar fasciitis affecting this very commonly. So for every case of plantar fasciitis you diagnose here, probably you'll diagnose 20 of these, and then you should be seeing one of these where the patient's pointing to the base of the fifth, and you'll see plantar fasciitis. This is not, of course, caused by an inversion injury. But what is caused by the inversion injury is a fracture of the base of the fifth metatarsal. And it's not caused by peroneus brevis, because this has a muscle belly attached to it, which can provide a spring-like action and relieve the tension on the base of the fifth, whereas the lateral band of the plantar fascia is a stiff, fixed piece of collagen. It tractions the base of the fifth metatarsal and causes the classic fracture. And these fractures are very common. This is just a case I just did the other day, the 1st of May, and I was following this peroneus brevis down towards the base of the fifth, and I've never seen this before. I noticed that all of this part of peroneus brevis was absent, and the peroneus brevis actually inserted here onto the peroneal tubercle. So if you just watch these videos, you can see I follow peroneus longus and brevis down, and then peroneus brevis just all of a sudden it inserts here while longus continues its journey, and when you go long axis on it, you can see that it's actually inserting onto the peroneal tubercle. So there are many variations of the peroneal tendons. There's what is known as the peroneus cautus, which is a collective name given to a variety of different accessory peroneal type tendons that attach onto the calcaneum, the base of the fifth, and other places. But this is a little different, because this is where peroneus brevis sort of got to here, looked at the journey ahead, decided, I don't think I can really make it that far, and I'll just make a nice home here on the peroneal tubercle. And I hadn't seen that before. These are fractures of the base of the fifth metatarsal. There's the fracture, and the fracture almost looks slightly proximal to the distal insertion of peroneus brevis, which is a clue that it's actually caused by the lateral band of the plantar fascia, which you can see here. Interestingly, the peroneus brevis is really almost sitting on the top of the base of the fifth metatarsal, and the lateral band of the plantar fascia sits on the lateral aspect. Whereas, you know, in my mind, I want the peroneus brevis to be on the lateral aspect and the plantar fascia to be underneath on the plantar aspect. It's not the case. Here's another fracture of the base of the fifth. These are very common. If the patient points to the base of the fifth and says they have pain, and then I ask the patient, have you had trauma? You're looking for a fracture. If they say, I've not had trauma, it's just built up over time, the pain, you're looking for plantar fasciitis in that lateral band. The next thing is the subtalar joint, because remember the ankle has a joint here, which is the actual ankle joint that can have an effusion in it, etc. And then it has the subtalar joint, and the subtalar joint is the articulation between the talus and the calcaneum. It has an anterior recess here and a posterior recess here. And we can see, there it is anatomically on the nice diagram here. And this area here, it looks like someone's taken a piece of bone out with a melon ball type tool. This is the sinus tarsi, which is full of fat. If we come down the peroneus longus and brevis tendons, as we can see here, imagine following these down. If we look anterior to them, you can see the articulation here of the subtalar joint. And then as we come further along, you can see you drop into the sinus tarsi, and this fluid that you can see in the sinus tarsi is this fluid here on the MRI. It sits in here anatomically on the diagram, and if you inject into this fluid here, which you can see just there on the ultrasound, this is an effective subtalar joint injection. So if you have ankle trauma, you're looking for a hemarthrosis or an effusion in the subtalar joint to suggest some orthopedic pathology. These are subtalar joint effusions, and this raises the question about there being some chondral injury or orthopedic injury in the subtalar joint that needs to be investigated by some alternative imaging to ultrasound. The next ligament is the calcaneocuboid ligament. Now, this little fella here is also called the bifurcate ligament, and it's this strut of it here, the bit that goes between the calcaneum and the cuboid, that I'm particularly interested in. And to be more precise, it's this piece here where the bifurcate ligament has its common origin on this sort of inferior anterolateral process of the calcaneum, because the joint traction of these two ligaments fractures the bone here and causes an avulsion. The usual mechanism of injury is when the hindfoot is stabilized and the midfoot goes through an internal rotation, opening up this CC line between the calcaneum and cuboid, and a little bit of plantar flexion of the midfoot will also aid in tightening this beyond its capacity and causing an avulsion and a fracture from here. This is the normal CC ligament. It's beautiful and slim and elegant looking, and this is what they look like in a normal healthy patient. And this is a CC ligament or bifurcate ligament where the distal end is okay, but the proximal end, which is the common site of injury, has been avulsed, and you can see the avulsion fragment there. You can also see the retraction of the tendon, and this is a ruptured CC ligament. Here's another one. It's quite a common injury. Once you start to look here, you'll see these fairly commonly. You can see the CC ligament here, but you can see that it's been tractioned off. The bone has been disrupted here, and we have an avulsion fracture here of this little protuberance here on that part of the calcaneum. And of course, the patient will guide you to that being a painful area. Yet another example of a little avulsion of the proximal end of the bifurcate ligament or the CC ligament. Here's a nice example of a CC ligament rupture, and you can see that it is really disrupted. And then I'm using some stress where I'm anchoring the hindfoot and I'm internally rotating the midfoot, and you can see that this ligament is gapping open, and the gap between the calcaneus and the cuboid is opening up, and there's a lot of hematoma here, and this is an extensive injury of the bifurcate ligament as part of an inversion process. If you go back to that last picture, you might notice that if I run those videos again, there's a little muscle that runs on top there. This muscle that goes over the top of the CC ligament is called the extensor digitorum brevis muscle, and it's the only muscle that you have on the dorsum of your foot, so that's quite a convenient thing to know. You might think, hang on, there's also an extensor hallucis longus, and that is true, but it's really just a name given to the most medial slip of this same muscle group. So if you see a muscle on the dorsum of the foot, it is extensor digitorum brevis, and it has its origin on the calcaneum, and it has its origin more precisely just slightly proximal, or posterior if you like, to that little protuberance where the bifurcate or CC ligament has its origin. So it's a very simple matter of finding the CC ligament and then tracking back along the calcaneum, almost so you're skimming along the edge of the sinus tarsi, and you can see where this muscle has its origin in this area here where its ligament has its origin. When you have an injury that involves significant plantar flexion, this will potentially tear this muscle, which we've seen a number of times, but also it may cause an avulsion of the extensor digitorum brevis origin. So this is the CT, which we did after we made the ultrasound diagnosis. It's one of those times when you're having a little bit of debate about whether the ultrasound could make the diagnosis, so then you go and do a CT. And the CT correlates beautifully, showing that it is not the calcaneocuboid ligament that's caused the avulsion. It is more posterior, and it is in fact the extensor digitorum brevis origin that has caused this avulsion. So here's a nice ultrasound example. You can see that the CC ligament would come on down here, but more proximal to that, we've got avulsion of the bone here, and this is the origin of extensor digitorum brevis avulsion. Another nice example. So two posterior, if you like, or proximal to be the CC ligament, which would be more inferior or distal. It's the extensor digitorum brevis with plantar flexion that has caused that avulsion. The dorsal talonavicular is the next one. If you have a hindfoot stabilization with straight plantar flexion, you may not actually tear your ATFL, but you can pop this fella, the dorsal talonavicular ligament. Very easy to see, because if you scan in the straight sagittal plane down from the ankle joint where you're looking for an effusion, just bring your probe straight down over the very oddly shaped talus until you get to the first genuine articulation, which is between talus and navicular. You will see the ligament beautifully. When it tears, it may cause an avulsion, or it may just look heterogeneous and swollen. And these are both examples of dorsal talonavicular tears. We then move to the other side of the ankle and go to the medial side, and we start to think about why that patient has bruising on the other side. We need to consider the deltoid ligament complex, and in particular the most posterior part, the tibio-talar part. And if you scan the tibialis posterior as it comes around, the moment the tibialis posterior separates from the bony medial malleolus, it will be sitting on top of this posterior part of the deltoid, which is the tibio-talar part. If you then put the ankle into dorsiflexion and eversion, you will tighten this ligament beautifully, and you'll see it very, very elegantly. When you do an inversion injury on the lateral side of the ankle, the medial side of the ankle comes together and collapses together to cause a compression injury of this ligament. Now, that compression injury will cause a post-traumatic synovitis, which we know as a POMI lesion, a posterior medial impingement lesion. I used to think that only this ligament could really be affected by it, but now I've seen really nice cases where the tibiospring and a recent one I'll show you of the tibionavicular ligament can also be involved. I don't think the tibiocalcaneal really does get involved in this. But this is what the normal tibio-talar, this red one here, looks like. It's a beautiful ligament. And this is what it looks like when it has a post-traumatic synovitis. You can see the SMI shows all this vascularity here. We can see the little chip fractures that have been taken off of the talus and the medial malleolus of the tibia. So this is the collision injury. Here we can see the edema, the swollen hypoechoic nature of the tibio-talar component, and then the hypervascularity. This is a classic posteromedial impingement lesion. Responds very well to a catabolic injection of one of our steroid agents. And that's perfectly what we should be doing with these. And these patients present some months after their, or weeks at least after their inversion injury, still with ongoing posteromedial pain. This person, this is not the posterior part. This is more anterior. This is more around the tibiospring area. You can see there's been a little bit of a collision and a little avulsion has come off here, but then you can see the fat around it is quite echogenic. So this is the more anterior part of the deltoid ligament that's also suffered a compression injury. When you have these posteromedial impingements and you get synovitis, another feature that you can see is that the inflammation will spread through the tissues. So the inflammation in this case begins in the tibio-talar, but then the inflammation, like a fire burning through tissues, then goes and involves the sheath of tibialis posterior and almost sets up a tibialis posterior tenosynovitis. So the inflammatory process will move through the tissues. This is the one I just saw the other day. What's the date on that? The 5th of May. And this is right around here. It's right around here on this anterior part of the deltoid complex, which I really don't much have time for. But this patient was tender here, and I could see that this tibionavicular component of the deltoid was very echogenic and swollen, looked very unusual. Then we put the colour on. I went, my God, it's very vascular. And this is really, if you like, a posteromedial impingement, but involving the anterior part of the deltoid. And so now I'm looking here and then looking more anteriorly as well, because it just depends on the vector of force as to which bit of the capsule, being the deltoid ligament, gets compressed, and look for the synovitis in that area. Another thing is tears of the deltoid ligament complex. Now, I don't think of the deltoid ligament as tearing because you need an eversion injury to tear it. But you can actually tear your deltoid ligament with an inversion injury, and I'll explain the mechanism by which this happens, because it's rather curious. It's well described with the MRI, and after reading those articles, I turned my attention to looking at this anterior part of the deltoid ligament complex here on the tibia for periosteal stripping, degloving type injuries of the deltoid ligament complex, and also the flexor retinaculum from this anteromedial part of the tibia. Well described with MRI. Now, what happens is with an inversion injury, these extensor retinaculums all get rotated with the inversion injury. And what that means, as they get rotated around, is that they put tension on through this mechanism here onto this thing, which is the flexor retinaculum, because these all combine as a part of a fascial continuum. Another thing you need to understand, if you look at this, this is the flexor retinaculum, and then you peel that away for this diagram, and this is the deltoid ligament complex. Now, hang on, they both look like they're inserting onto the medial malleolus. So how do they get this arrangement organised? Well, what they do is they join and make a conjoint attachment, and you can see that beautifully with ultrasound just at this location. So as we have an inversion injury, you'll have degloving and avulsion of the flexor retinaculum and the deltoid ligament complex from that inferior medial malleolus. So this is the normal anatomy: tibialis posterior, flexor retinaculum over the top, and there's the deltoid ligament coming underneath. And you can see they make a beautiful conjoint attachment onto the medial malleolus. When it goes awry, you can see this is the same piece of anatomy. This is done on the 9th of February this year. And you can see that this same piece of anatomy has been degloved from the bone. So there is a hypoechoic line running along the periosteum, and the soft tissues are grossly swollen and hypoechoic. There's another case on the 5th of May, so what's that, a week or so ago, just recently anyway. And again, you can see how either side of tibialis posterior, you've got the flexor retinaculum, then underneath it you've got the deltoid ligament complex being degloved from the medial malleolus, and in this case it's very vascular. And just note how beautiful this A500 is when you put the Doppler on, how it maintains the B-mode quality. Is just so nice to scan with. Another area to look at is the fibular origin of the extensor retinaculum, where this extensor retinaculum comes off the fibula. I don't have a case of pathology to show you here, but I'm really showing an interest in this now, and no doubt within a year or so I'll be able to show you something. And then there's the miscellaneous things, like when the patient says, I'm really sore here, well, go there. All of this collagen is up for grabs. And if they look at, say, a navicular cuneiform, which is this little ligament here, sure, it's easy. Ankle joint, talonavicular, navicular cuneiform metatarsal. Just work your way down the shopping list. And if they're sore here, I look at it. And then if you look, you see. So here's an abnormal compared to the normal navicular cuneiform ligament. It's an unusual injury, but they must have had some sort of almost midfoot stabilization with the metatarsals being pulled down into plantar flexion to cause that injury. The next thing is anterolateral gutter impingement. And this is where you've had an inversion injury and you're recovering from it. And it should granulate into a nice, freshly made joint capsule, not made of collagen, but made of scar tissue to hold that precious synovial fluid inside the joint, and also to give you back some strength to stop the inversion injury happening again. However, occasionally the repair job, like that last one and like this one, is over-exuberant, and there is a hypergranulation response around the ATFL. And then this will lead to an anterolateral gutter impingement, where the patient will present with stiffness in the anterolateral gutter. They won't be able to go through their full range of movement. They'll feel tightness and soreness in this following the injury. And these are all examples, and this one's just from the 30th of April, a really nice, good example of a hypergranulated anterior talofibular ligament, which is giving ongoing symptoms, and it will continue to give ongoing symptoms until it's debrided out and allowed to try and heal again. This brings us to what does granulation look like and what does collagen look like. So this is collagen, it's got long straight lines in it, and this is granulation, it looks like particle board. So remember that, 23-year-old female, if she played a bit of netball, grew up in the country, played netball, played on the wet bitumen courts, she is going to have had some inversion injuries. So this may be a standard finding in many people when they've had an old inversion injury, and this one's healed up really nicely. It doesn't look like a normal ligament, but this is a standard sort of reconstituted, granulated ATFL that we expect to see once you've had the injury in the past. What do we do badly? Well, we miss some things. We miss talar fractures, but so do the plain x-rays. So when we see a hemarthrosis, we need to go looking for a talar fracture, talar dome, other orthopedic fractures. We don't see the bone bruising. We're pretty rubbish at the posterior inferior tibiofibular syndesmosis and the intermalleolar ligament apparatus at the back. You can see it with ultrasound, but I don't think we can really be diagnostic in the way that the MR can. So it's one of those things that sort of falls into the category a bit like the posterior cruciate, like it's all very well to say we can see it a bit, but I don't think we actually add anything diagnostically, and so we shouldn't be going there in the first place. The interosseous membrane, we don't see this injured, and this is an MR diagnosis. And of course, chondral injuries, we don't see the images to the cartilage that can happen as part of these inversion injuries. And that brings me to the end of inversion injuries. If I've still got a few minutes, and let's see, yes I do, I think, I'm just going to show you one more thing in the neighbourhood. And that is another type of hypergranulation which we might see in people that have had a tennis leg injury. So it's quite close to an inversion injury. It's where you rupture or tear your medial calf. And this schematic shows the calcaneum, the Achilles tendon, the soleus muscle insertion, and the medial gastrocnemius insertion. So the the Achilles is called the trisurate because it has 3 muscle bellies that are attached to it. So you have 3 musculotendinous junctions. The soleal musculotendinous junction and the lateral gastrocnemius musculotendinous junctions can be injured but are relatively benign. The medial gastrocnemius musculotendinous junction is a hot spot for pathology. So we very typically tear this, and then we get a bit of bleeding in here. And this is your classic tennis leg injury. And then this has to heal. Now, when this heals, if it heals neatly, that's fine. But we see very commonly, and this is poorly described in the literature, which we may have to publish something to add to the body of knowledge, this often undergoes a hypergranulation healing response. So this is your classic tennis leg injury. You can see how this is the stump of the Achilles here, proximally, on the medial side. It's retracted back a little bit. Remember, the Achilles, when it's at its musculotendinous junction, is very thin, very flat, and very broad. You can see here how the medial gastrocnemius has become disconnected from it. So this is the acute injury. This is what we see in the acute injury. There's an intact plantaris tendon going underneath it that is unaffected by this injury. Here's just some more pictures of the same patient. So this is the Achilles. There's the plantaris going under. The medial gastrocnemius has been disconnected from the Achilles. Classic tennis leg. The way I describe this is a medial gastrocnemius, Achilles tendon, musculotendinous junction tear with an intact plantaris tendon. That's how I describe it on my worksheet. But what happens in these patients is, instead of having a nice bit of granulation, they get this thick granulation that forms in this area here. And if you follow the Achilles tendon up, doesn't matter if it's long or short axis, you'll notice this thick area here that is between the medial gastroc and the soleus muscle, where you expect the plantaris tendon to be. And if I look back in my film library, I've got many cases labelled in there as plantaris tendinosis. And that was, of course, MSU, okay, so making something up, and because I just thought that's what it was, but now we know better. And when we look at these cases more carefully, if you watch this one, if you watch the plantaris tendon, which is here, it goes in underneath the Achilles and is perfectly normal. And then it's actually the Achilles tendon musculotendinous junction that is hypertrophic and enlarged. And what this is a hypergranulation response to healing. So it's a thick bunch of scar tissue, and the patient will present with tightness and stiffness in that medial calf well after their injury is healed. This is a person with a fairly acute injury, and you can see plantaris is intact, and I'm betting this person's going to head down that pathway because you can see it's already granulating in quite a broad way here, and this was fairly recently after the injury. So this is a hypergranulation response to an injury, much like we get with the ATFL causing anterolateral gutter impingement. And we see this commonly. This is one from the 12th of January this year, and I think this is actually a really common entity that has just been fairly poorly described. And now I hope you'll know what it is and give it the right name. What I don't know is how to treat it, and there's some debate in our practice about, and with my colleagues as sports physicians, as to how we go about treating this patient, and we're not sure what to do. And I think we might leave it at that. That is about 40 minutes worth of goodness, and that gives us a bit of time for some questions.
Thanks, Steve. Could I ask if anyone has any questions to please write them in the chat feature, and we'll start asking Steve.
Now, I know there's about 111 or so out there, so surely there will be some nice ones. Here we go. How do we stress the ATFL? So the ATFL, my radiographic background tells me that there's an inversion stress test. You've got to remember, I'm an old radiographer, right, and getting older by the week, sadly. So back in my halcyon days of my best X-ray work, I would help a radiologist to don the lead gloves, and they would put the patient through a painful inversion test and then an anterior draw test while I took the X-rays to show the laxity of that ankle mortise. And so I effectively do the same with the ultrasound. Now, the one that I showed you was just pure inversion stress, and I find that to be the most effective. So when I scan an ankle, I put the foot of the patient slightly off the end of the bed, and then if you just ask them to internally rotate their hip slightly, the weight of the foot will put a little bit of passive inversion stress on the anterior talofibular ligament. And then if I want more stress, I simply scan with my right hand and I just invert the foot with the left hand, and that's how I do it. What external landmarks do you use to find the CC bifurcate ligament? It's a very easy thing to find. The way I find the bifurcate ligament is I put the transducer on the heel, back on the calcaneum, parallel to the sole of the foot. So it's a dumb picture looking at a rugged piece of bone. I then slide the transducer towards the toes, so towards the little toe in this case, and you'll notice that the calcaneum will give way to another joint and another bone, and there's a joint. Now that joint will have a little step down. The cuboid will be slightly deeper than the calcaneum. So now you've found the CC joint, the calcaneo-cuboid joint. To find the bifurcate ligament, you then need to move the transducer, slide the probe in the dorsal direction, so up the foot a little bit towards the dorsum of the foot, and that gap in the bones, that step, will become greater in distance. Now, if you go past the point of the bifurcate ligament, you will still have the calcaneum, or you'll drop off the calcaneum into the sinus tarsi, and you'll lose the cuboid and you'll see navicular, and I feel like I've lost my way. So you need to be at the point where that gap is at its maximum before you drop off those two bones, and if you look there, you'll see the beautiful CC ligament running obliquely. It's slender, its distal insertion is not right on the edge of the cuboid, but is a fair way down the cuboid, and it's a lovely slender little ligament. So I hope you can find that. I can't see the calcaneo-navicular component of the bifurcate ligament well. I don't have a technique for that, but really, I'm really interested in the proximal end of the CC ligament, not the distal end. It's where it's attached to the calcaneum, because it's the common root of that bifurcate ligament that takes the strain. Differentiation between subtalar and sinus tarsi areas. Okay, so the sinus tarsi is the well of fat that sits just distal as you come down the subtalar joint. So as I'm coming down, so the subtalar joint is the joint between the talus and the calcaneum. So as I'm coming down the peroneal tendons in short axis, I will see the calcaneofibular ligament go underneath the peroneal tendons, and then immediately as that's happened, if I just look slightly anterior to the peroneal tendons, I'll see a gap between two bones, and it's a very tight gap. It's a narrow joint. Now that is the subtalar joint, because that's the joint between the calcaneum and the talus. If I continue to move the transducer a little bit further down, still following along the line of the peroneal tendons in their short axis, you will continue to have the calcaneum, but the talus will disappear. And once the talus is gone, it's replaced by this big well of fat, and that is the sinus tarsi. And when you see some fluid that is sitting in the sinus tarsi, that is pressed up against the edge of the sinus tarsi, that is adjacent to the subtalar joint, that is simply an anterior expression of fluid from the subtalar joint pressing into the fat of the sinus tarsi. And there's a beautiful article, if you email me, I can send it to you, showing that if you inject into that fluid that's in that location, that injection will in fact be a perfectly adequate subtalar joint injection. So it's a very easy way to inject the subtalar joint if they've got a little bit of effusion, and mostly patients with subtalar joint disease have a bit of an effusion, so that works out very beautifully for us. One more time, differentiate between subtalar sinus tarsi. Done that one. The case of anteromedial impingement injury, did the patient have an intact ATFL? I can't remember. No, I think from memory, I think it was only the other day, I should be able to remember. I'm pretty sure that patient had what looked like an old granulated ATFL. So I didn't give them an acute injury, and yes, their CFL was damaged, and they had that anterior compression at the front of the ankle there. So I guess it makes sense that the CFL with that sort of compression at the front of the ankle, the CFL being the more sort of posterior component of stabilising, is going to have to give way to allow that to happen. And their ATFL, Peter, I think was a granulated one. So when they're granulated, they often will survive an injury anyway, because they're just some scar tissue, and so they're not so susceptible. Collagen versus granulation, easy. Collagen looks like lines, linear lines. Granulation looks like particle board, little spots. So if you think about what collagen looks like in the Achilles tendon or the tibialis posterior, peroneus longus and brevis, collagen is straight lines. You see beautiful lines of collagen. If you think about what something made of fibrocartilage looks like, so a meniscus, a labrum, the triangular fibrocartilage, it looks spotty, and that's what granulation looks like. It looks more like spotty tissue than it does linear lines. So if it was in a tendon rather than a ligament, if you see that spottiness inside a tendon, the particle board type change, that is tendinosis, where the collagen has been replaced by ground substance. But in a ligament, it means that the ligament has been previously torn, because ligaments don't get tendinosis. Ligament has been torn and it's been reconstituted with granulation tissue or scar tissue, and that's what it looks like. Yes, it is possible to see this presentation again. I think Toshiba will have it on their website in about 90 days. And if you also go to birdultrasound.com.au, if you send me an email and ask me to see the webinar again, I will be able to provide you with a link through my website to see the same webinar, but in 90 days, because that's because you guys are paid for it. We don't want your work colleagues to see it tomorrow for free, but it will come up on the website in about 90 days. Can we look one more time at this presentation? Same thing, I think. Yes, 90 days, you can look at it as many times as you like, and I hope you do. So please come to the Toshiba ultrasound website and the Bird ultrasound website and log in. You have to get a little username and password from me, but I'll give you that and give you access to those webinars. Very good.
Hi, Steve. We just missed one that slipped through the cracks. Which nerves do you routinely look at in a foot?
Okay, I didn't see that one. Where was that question? Which nerve do I look at in a foot? So, nerves in feet are fascinating things. With an inversion injury, if it's purely for an inversion, yes, Helena, thank you. I do not look at any particular nerves in the foot for an inversion injury. But if the patient presents with symptoms that I think are neural in nature, then there are many nerves to look at in the foot, and I'll run you through some of the ones that I look at. So if the person has metatarsalgia or medial arch pain, so pain around the forefoot where the Morton's neuromas live, or in the medial arch, I will look at the tibial nerve as it comes down around the medial malleolus, because the tibial nerve is where the tarsal tunnel is, and I'm looking for anything that is a ganglion or a nerve sheath tumor or anything that is putting compression on that tibial nerve. So I'm very interested in the tibial nerve. You'll then see from the tibial nerve a very tiny branch, which you'll only see if you're scanning on like an A500 with the matrix array high frequency probe. It's a very hard little nerve to see, but you will see the first branch of the lateral plantar nerve come off the primary trunk of the tibial nerve, and that's what some people call Baxter's nerve. Seeing that nerve itself, I don't think is that important, but I'll talk more about that in a second. Then you'll see the division you'll see the division of the tibial nerve into lateral and medial plantar. From the lateral plantar, you'll see the Baxter's nerve. And then I like to follow the medial plantar nerve down through the tarsal tunnel. It goes between abductor hallucis, so that's your big toe abductor, and quadratus plantae, which is one of the intrinsic muscles in the middle of your foot. It goes through a gap between those two muscles, and then it goes through the longitudinal medial arch immediately adjacent to flexor hallucis and flexor digitorum tendons, which are known as the knot of Henry, and it can become irritated in that area. So I look at that apparatus for patients with medial arch pain or metatarsalgia. If they've got plantar fasciitis, and I think their plantar fascia looks good, then I want to see if that Baxter's nerve, the first branch of the lateral plantar nerve, might be getting damaged underneath the plantar fascia. So then I go to the lateral side of the foot, and I come down the calcaneum in short axis, down the lateral aspect, and then I notice when the calcaneum finishes, I see the next bone appear. That next bone is the cuboid. That bone will be slightly more superficial on the screen, and on top of the cuboid, between the cuboid and your transducer, you will see the peroneus longus tendon wrapping around the cuboid. Superficial to that, you'll see a muscle belly, and that muscle is abductor digitorum minimi. And if that muscle looks black, your Baxter's nerve is good. If that muscle looks atrophic and white, your Baxter's nerve is a problem, providing that the other muscles in the foot look nice and black. If the patient has pain or sensory symptoms between their first and second toe, you need to look at the deep branch of the peroneal nerve, because that innervates the little gap of skin between the first and second toes. So if you follow the dorsalis pedis down over the dorsum of the foot, you will then notice that next to it there's a tiny nerve, and this is the deep branch of the peroneal nerve. And this little nerve sits right on top of the midfoot articulation. So if you have any talonavicular, navicular cuneiform metatarsal osteoarthritis that are forming some osteophytes, then the nerve will be sitting and pinched on top of those, and you'll get a neuroma forming there, or some neural edema, and they'll have their symptoms in that webbing between the first and second toe. It's a very classic clinical presentation. The other nerves around the foot that you might want to look at are the superficial branch of the peroneal nerve, and with an inversion injury, that's probably the one that you would look at, because with an inversion injury, you can get traction of that superficial peroneal nerve, and as it exits between the muscles, between the peroneal muscles and the anterior compartment muscles, and enters the superficial sort of subcutaneous fascia, you can get a traction of it there, and you can get a post-inversion injury neuroma in that location. It's rare. I don't have nice cases to show you. I've got a beautiful case of a peroneal neuroma we saw just the other day, but it wasn't involved with a traction injury. So I think while we talk about this, I'm not sure it's very common. And the last one, I suppose, is the sural nerve around the back. I think that's probably all it is for nerves. When you see some fluid deep to an intact ATFL, is this significant? No, it's not. Fluid deep to the ATFL is joint fluid. The ATFL is the joint capsule. So all you're seeing is natural, harmonious, healthy synovial fluid. If you notice there's an echogenic blob sitting in that fluid, that's fat, and it's normal to have fat underneath the ATFL sitting in the joint. That's normal as well. However, if I see a lot of fluid underneath the ATFL, it's very, very simple. You go to the anterior ankle joint, so you come down the tibia with your probe in the sagittal orientation. You put the probe between, so you're looking at the tibia and the talus, and you look in that anterior ankle joint for an effusion. If there's fluid there, then the patient has an effusion. If that looks dry, just with fat, then the patient is normal, and the fluid under the ATFL is beautiful, lovely lubricating grease for the ankle joint, and that's all.